All right, so today we're going to talk about rheumatology. The stuff that we're going to be talking about today is pretty straightforward stuff. It's nothing really too crazy. And this material will be on exam 3. It was going to be on exam 2, but I felt like it was going to fit better with the stuff that you'll see in exam 3. So that's why I shifted it over a little bit. So let's get into it. This is a famous painting of a man suffering from gout. And gout used to be associated with the aristocracy, people in royalty. Right? Why is that? Why do you think that it was mostly associated with rich people back in the day? Nowadays it affects poor people alike. Right? But back in the day, gout was mostly a phenomenon of the wealthy. Lipids, you're getting close. It's a dietary thing, yes. So lots of foods rich in purines. So lots of red meat, lots of fish, lots of alcohol, so booze. So these are all the things that were afforded by the ruling class, aristocracy, people like that. It used to be kind of like a mark of privilege if a person actually came down with gout, because it showed that they were like living a life of excess and indulgence. And so this painting shows a little demon, the little gout demon, putting hot coals on the guy's foot, because gout is mostly going to affect the large toe. Okay, it can affect other joints as well, and it can affect the kidneys, and it can affect a lot of different parts of the body, but it's mostly going to be affecting the large toe. We're going to talk about gout in a little bit, so I'll tell you my gout story from when I was doing my clinical rotations. I had a patient with gout, and he was a raging alcoholic, and it was kind of a funny story. So these are all the things we're going to talk about for rheumatology. We're going to briefly discuss sprains versus strains. We're going to talk about epicondylitis, so golfer's elbow versus tennis elbow. We're going to talk about Osgood-Schlattler's disease, bursitis, et cetera, et cetera, et cetera. And then we're going to finish off with the difference between rheumatoid arthritis versus osteoarthritis, and the only cancer we're going to talk about in this class is going to be osteosarcoma. But there are other cancers that affect cartilage as well as bones. But osteosarcoma is going to be the main one that we're going to be talking about for this class. So, sprain versus strain. So going back to some basic anatomy. So going back to your guys' Bio 210. Ligaments are what attach bones to bone, right? Versus tendons are what attach muscle to bone. And so if you were to inflame or damage a ligament, that would be considered a sprain. If you were to inflame the tendon or the muscle, that is a strain, so with a T. And avulsion is going to be where you have complete detachment from the bone. So there's avulsion fractures, for example, where you have a portion of the bone actually coming off, and it's going to be remaining attached to the tendon. So if you have an avulsion, it's where you have complete detachment from the bone. And of course, there's going to be different gradations of severity of sprains versus strains. So here is, a common type of sprain that you might see at the ankle, right? So if you, especially if you're wearing, if you're a female, you're wearing high heels, this can happen, right? So if you invert your foot too much, you're going to strain the lateral side of your foot, right? All the ligaments on the lateral side. Versus if you evert your foot, you're going to be spraining the medial ligaments of your foot. So here are your gradations of sprains. So there's going to be more mild type sprain where you have like a little bit of a damage, inflammation of the affected tissues, a little bit of tearing. If you have complete tears, that's going to be a grade 3 sprain. The signs and symptoms of sprains, it looks a lot like the signs and symptoms of a broken bone. As a matter of fact, a lot of people who get a sprain, they'll think that they maybe broke their bone. This happened to me once when I was hiking. I jumped off of a ledge that I didn't think was too high, but I landed on my heel. I thought I broke my foot, and for like a week and a half, I was walking around. This is when I was doing my clinicals. I was hobbling around using a cane, and my supervisor, after a week of seeing me hobbling around, was like, "You should probably go down to the ER." I was like, yeah, you think? And I was like, you never, when you're a medical student, you're kind of like treated like trash. And so it usually takes a while for your supervisors to actually feel a little bit of sympathy for you. So they let me go, leave my duties as a medical student in the hospital to go get an x-ray. I was very nervous because I thought I had a calcaneal fracture, which is like one of the worst bones in your body to break. Because if you have a calcaneal fracture, you're going to be immobilized for 12 months. I actually had a guy knew a guy that had a bilateral calcaneal fracture. He was drunk one night, jumped off the roof of his house, landed on both of his heels, broke both of his calcaneal bones, and he was immobilized for 12 months. So it's a horrible bone to break because it's the main weight-bearing bone in your body, right? Because all of your body weight is on your heel, right? And so I thought I broke my calcaneal bone. I was freaking out, and so I went to get my x-rays done. The docs said, you don't have any broken bones. So thank God for that. It was just a really bad sprain of my ankle. So basic treatment for that is rice. Well, at least when I was in med school, it was rice. Now we've changed the protocol a little bit because you want to add some mobility. But rice used to be just rest and ice. But now there's, you add mobility to that so that you can maintain your normal function. So that happens quite often. Some people think they break a bone, but in fact, you just either irritated or ruptured a ligament instead. So if you have a grade 1 type sprain, you're going to do, instead of rice, you're going to do crime. So crime, you want to do compression, you want to do the ice routine, rest, ice, but you also want to involve motion too, because you want to maintain mobility of the affected area. And then elevation is another good thing to do. Elevation where you bring the affected area above the heart so that you're not getting so much blood pooling into the area. So that helps to reduce the inflammation. Bless you. And then grade 2 sprains, you can do this whole process plus splinting. And then if a grade 3 sprain, if it's completely ruptured, you're going to have to get surgery to repair that, right? So think about like an ACL tear. An ACL tear is not going to repair itself. When you rupture the ACL, you're going to have to get surgical intervention for that. So anytime you rupture a ligament, you'll have to go into surgery. Even a tendon, if you rupture a tendon, you have to go get that fixed surgically as well. So one of the largest tendons in your body is going to be your calcaneal tendon, right? So it attaches to your calcaneal bone. If that ruptures, you have to get that surgically repaired. Right? And that's actually a pretty, it's uncommon to get that ruptured because it's so big, but a common vignette that you guys might see in your future board exams is a patient who recently had an infection and took a fluoroquinolone drug, so ciprofloxacin. Ciprofloxacin is a drug that affects DNA repair in the bacteria. So it affects the topoisomerase in bacteria, and so it kills the bacteria, but can also affect your ligaments, or sorry, your tendons. So if you get large tendon rupture after taking an antibiotic, it's usually because you took ciprofloxacin. So if you see that on a board exam in the future, that's one thing you might see, not only in an exam, but you could also see that in your patients too, right? So very rare to rupture a calcaneal fracture, but it can happen. And you hear like a loud, audible snap, and then all of a sudden your foot's immobile. So really nasty. It's a nasty tendon to rupture. So here's your grading again. So if you have a grade 1 sprain or strain, you're getting a little bit of damage. If you get partial tears, that's grade 2. If you get complete rupture, complete tearing, that's going to be a grade 3 sprain/strain. All right, so let's move on to the epicondyle and tendinitis. So the main ones that I want you to be familiar with are going to be your golfer's elbow and tennis elbow. So if you have epicondylitis, that means that you're having inflammation of the tendons associated with the epicondyles. So for lateral epicondylitis, maybe think about somebody doing like a backstroke on a tennis racket. And so lateral epicondylitis is going to be your tennis elbow. And maybe think about like when you're playing golf, right? Maybe your medial side where you're swinging the club. If you get medial epicondylitis, that's going to be your golfer's elbow. So What do you do to treat it? You just give the person NSAIDs. That's basically what you do. So you just give them anti-inflammatories to help reduce inflammation and to reduce pain at the site of the injury. And, of course, maybe abstaining from any rigorous exercise or anything like that. Osgood-Schlatters disease is going to be tendinitis at the anterior patella tendon, and it's going to be affecting the tibial tuberosity. Okay? So you can actually see this on an X-ray, and if you diagnose a patient with Osgood-Schlatters disease, you just tell them to get some rest. Right? Just try to avoid any sort of strenuous exercise with the knee. Dislocations. You can dislocate several different joints in your body, but one of the most common ones is going to be the shoulder girdle, especially anteriorly. The anterior portion is a lot more vulnerable on the shoulder girdle. You can get other dislocations, like the femoral head can dislocate, but that's usually involving like really severe trauma. So that can happen in like car accidents, motorcycle accidents, things like that. But the most common one is going to be your shoulder joints. The biggest issue with these types of dislocations is the potential damage to the vascular system. So you can damage the veins, you can damage arteries, and you can also damage the nerves too. So those are the biggest concerns with dislocations. Diagnosis is pretty obvious. When you have a shoulder dislocation, you're going to see drooping of the affected arm. And you do want to get an X-ray on these patients, because usually a dislocation is going to be associated with like some sort of injury for the most part, unless the person gets them chronically, right? There's some people who actually get dislocations chronically and they're just used to it. Once you get a dislocation, you're going to be more prone to getting dislocations in the future. And so a person who gets these chronically, usually they can just, they can actually reduce it themselves and put it back in place. But if a person gets it for the first time, you want to do an X-ray just in case the person might actually have like a fracture involved with the dislocation. What's your question? Oh, yeah. What did you say? Ehlers-Danlos. Yeah, I was going to say Herb Duchenne's palsy. Ehlers-Danlos. Yeah, there's people with Ehlers-Danlos where they have like really stretchy skin. They have it's like a mutation of their collagen fibers, and so they can be predisposed to that. They can be predisposed to a lot of things, even like aneurysms, because even their vessels are going to be kind of compromised. So yeah, what's up? Do you really? Chronic what dislocation? Knee. Oof. It kind of like just deviates over to the side. Oh, wow. Horrible. Right. The criteria to meet Ehlers. Yep. Yeah. Are you double jointed? Ooh. Wow. Yeah, that's wild. Your fingers are not supposed to bend that way normally. So that's interesting. So did you meet the criteria for Ehlers-Danlos? You did. Did you get the genetic testing done too? ADHD? What's the link there? That is interesting. Well, you're really good at sending me articles, so find an article that talks about that and send it to me, because there's a lot of rabbit holes. Well, when it comes to genetics, you can go down lots of rabbit holes because there's a lot of interesting, correlations between certain genetic conditions. So that's really fascinating. Yeah, I wasn't aware of that. Is it because of muscle mass? Hmm. Right. Yeah. It just kind of floats there. Yeah. Yeah. Is it painful? Is it painful? Yeah, you would just do it yourself. Oof. It would just happen randomly. Yeah. Wow. Wow. Yeah, that's wild. Well, if you need to get someone to actually put it back in place, this is a video that demonstrates that process of putting a dislocated shoulder back in place. Like I said, some people get this so often that they just learn how to do it themselves. I really hope they weren't playing that song in the clinic while they were doing that. Anyways, here's another image of what a dislocated shoulder would look like, and that's what you would see on a radiograph. All right, so any questions on dislocations? Cool, so let's talk about bursitis. You have bursa in lots of different areas in the body that provide like cushion and support. But if you have inflammation of bursa, that's bursitis. And so generally speaking, it's going to happen with repetitive type of motions, repetitive actions like constant inflammation and repeated trauma. You can get it in your shoulders. Musicians can get this. Tennis players get this as well. But then the other ones that are a little bit more specific are these three. So the ones that I want you to be familiar with are bunions. So you can get bursitis of your, again, your big toe, your hallux. This is very common in women who wear really tight-fitting shoes, high heels, things like that, right? All the pressure is like constantly poking into the front part of the shoe. And so over time, that can cause bunions. And the housemaid's knee is another one. This is, you can get that as being a mechanic. You can get if you're doing lots of type of work at home or something like that. That involves you being on your knees a lot. And so housemaid's knee is where you have bursitis of underneath the patella, and then student's elbow is where you have bursitis of the olecranon, so your elbow, and that that happens if you're like resting your elbows a lot on a table desk. My colleague Michael Barton has that, and I asked him a couple weeks ago, like, what's with the elbow brace? And he's like, I got student's elbow, and so he wears it despite the fact that it's probably good now. He probably doesn't need to wear it, but it's like Murphy's Law. When something's inflamed, you're probably going to bang it on something more so than not. Murphy's Law, right? So he was saying that whenever he wasn't wearing it, he would like always bang his elbow on something, and he still does it. Yeah, he's for his Spartan race. Yeah, that's what he said. Yeah, he's a Spartan guy. Yeah, he's a strange fellow. Michael's cool. Apparently clumsy though with his elbow. So here are some other images of what that looks like. So here's your bunion, and then here's your housemaid's knee, and then your student elbow. So the reason why you get that, of course, trauma, right? You can get that from repetitive stress injuries. There's other conditions that can predispose a person to getting bursitis. So rheumatoid arthritis, certain infections, diabetes, HIV, gout. You can test this if you can't really feel it. You can also test this by using an MRI to see if you see any inflammation of the tissues that are associated with the bursa. And then treatment, rice. So rest, ice, NSAIDs, corticosteroids, reduce the inflammation. That's going to be a very common treatment among a lot of these different conditions that we're talking about today. All right, let's now talk about carpal tunnel syndrome. So carpal tunnel syndrome, not fun. And it kind of happens to people who, what's that called? Is it ergonomics? Where you have like really bad like posture, right? So if you're typing a lot and you have like repetitive stress and bad type of posture, those kind of scenarios can predispose a person to getting carpal tunnel syndrome. So effectively, what's happening is that you have the transverse carpal ligament impinging upon the median nerve, right? And so this is going to be more common in females. And the types of symptoms that you're going to see are like tingling, numbness, pain, sometimes kind of like a burning sensation. And you're going to see this on the palmar side. And there's going to be the medial fourth and fifth phalanges are going to be spared. So you have some sparing of, depending on what nerve is mostly affected, right? The median nerve, you're going to see sparing of the ulnar nerve, of course. And you're going to see this happening mostly at night, because at night, when you're sleeping, you tend to like flex your wrists at night. So, how do you test for carpal tunnel syndrome? It's mostly going to be clinical testing, right? So you can do a physical exam. So there's two major ones. There's going to be the Fallon's test and there's the Tinel's test. And you can also do a nerve conduction test as well. But the Fallon's test versus the Tinel's test, let me go ahead and show you what that looks like first. So the Tinel's sign is literally where you just tap on the medial portion of the person's wrist. And if you tap on their wrist and it elicits pain, right, then that's going to be a positive Tinel's sign. The other one is the Fallon's sign. And so you're going to flex your wrists at a 90-degree angle, and you're going to have the patient hold that position for about 60 seconds to 2 minutes. And then if you can elicit numbness and tingling and pain in the person's hand, then that's, again, a positive Fallon's test. How do you treat it? You could do corticosteroid injections. I would suggest that first before you go into surgery. Surgery is, you want to try to be conservative when it comes to surgery. You want to do other options first, and then if it doesn't improve, then you can go ahead and do surgery. So I wouldn't put surgery first, even though I put it there as the first option. You would want to do things like corticosteroid injections. Then if those fail, then you can go into a surgical procedure. So here are some of the images of what the surgery for carpal tunnels would look like. And you would literally just go in there and sever that transverse carpal ligament so it can be released. So let me show you a little video of a different type of procedure. This one's a little bit less invasive. This patient here has a beer block or an IV regional. They should be pretty well anesthetized. Right now we're just going to be making an incision right over the area of the carpal tunnel incision site for carpal tunnel relief. Just a small incision here with them. We spread down to the forearm fascia. Get to the forearm fascia, that's where we start to make our release. Grab the distal end and cut with scissors the proximal end. Once that's released, about a centimeter down, then we go ahead and dilate from the carpal tunnel. So this is a dilator here. Dilating first with a smaller diameter, the size of the tray.
This is the tray we use. This is from Segway, so it has a slot for the scope, one slot for the knife. So we put that in so the knife side is directed onward, and the scope side is directed right. This is placed in there, and we put the scope in. Once the scope is in, we're taking a look. Medium. Go up one line on the back of the light there. A knife clip. Down below, yep. That's it. And now we insert the knife in the knife tray. Grab hold of that edge. Once we get it, we just go ahead and release it. All the way across. I may need to get down some of that. Go ahead and take a picture. Back up a little bit. Back up a little bit more. And just to confirm we did the release, take the tray out. That was a complete release. Distal proximal. Make sure that we've got the whole thing released. And all we're seeing is the fatty tissue. That's that. Let's go ahead and put some sutures in that.
Quick, huh? Look how fast that was. It's ridiculous.
We can do the other side. Pick up. So this is just a simple small incision that we can close with a simple mattress. Simple suture. That's it. That's one part down. Two parts. Endoscopic carpal tunnel release is the Segway system.
Incredible, huh? Super fast. Next. Good soundtrack. All right. Any questions on carpal tunnel? What's up? You mean when they have before the procedure or after the procedure? I don't think so. I don't think so. I'm not really sure what the long-term prognosis is after you get that procedure done, but it's pretty minimally invasive, but I don't think it actually does affect much of the mobility afterwards. But I'd have to look into that to be sure. What would be the next step after they do the surgery and they still have that? The surgery should correct that. They shouldn't be getting that again because it's mostly due to that transverse carpal ligament. Right? Once you cut that ligament, that's basically it. So it really shouldn't reoccur. But like I said, I don't know what the long-term prognosis is of that procedure after it's done. So I'd have to look into that. But if they continue to have symptoms, I don't know. I'm not sure what the next step would be after that. Amputate the arms. Just kidding. I don't know. I'd have to ask a hand surgeon. Yeah, that's a good. These are really good questions, way beyond my scope of understanding. I mean, when I was doing my orthopedics rotations, there was a gal that I worked with. She was focusing on hand surgery. That was her focus. Like, if a person wants to do hand surgery, they can do like entire residency focusing on just that, and then even maybe do fellowships as well in that field. So it's a very specialized field that can't answer those types of questions. But good questions, though. I love it. All right, sciatica. Sciatica, you have your sciatic nerve. It's one of the major nerves in your leg. And sciatica is where you have nerve compression, causing pain, inflammation, even things like the loss of bladder and bowel control if it's severe enough. So there's different ways you can get sciatica. You can have muscles being involved, so you can get muscles that are impinging on the nerve. That's especially with piriformis syndrome. If you have herniated discs, that could also cause sciatica, right? And then also if you had cancer. So if you had a tumor that metastasized to the bone, that could also affect the sciatic nerve as well. What do you see in terms of signs and symptoms? You're going to see that pain radiating from the back down to the buttocks, down to the lower leg. You'll see neuropathies involved in that too. So like pain, numbness, tingling sensation, all those things are going to be seen with sciatica. And then how do you test for it? You can do a couple things. You can do MRIs, CT scans, you can do X-ray. You're going to, with an X-ray, that would be really good to see if there was any sort of like bulging discs or herniated discs. For muscle involvement, then you'd want to do MRI. MRI is going to be really good for seeing like soft tissue issues. You got a question? Oh man, I forget the underlying mechanism of piriformis syndrome. I would have to look into it to get. Let me get back to you on that one because that's a good question. In terms of like where the nerve goes, and I don't know the exact details on that. It's not nutcracker syndrome. That's involved in the kidneys. Yeah, I have to look into it. Yeah, yeah, exactly. Yeah, that's totally it. But I think it's kind of like a similar type of mechanism. Where it's like pinching. Uh-huh. Yeah, yeah. No, that's a good question. I'd have to look into that. Let me make a mental note of that, or make a note on my computer so I can look into it later. Um, Mechanism of piriformis syndrome. Okay. All right. Any questions with sciatica? By the way, this is very common. My mom had sciatica. She's doing a lot better now. So she was actually just doing muscle relaxers. She didn't go through surgery to get it corrected. She was taking muscle relaxers, and she was doing a little bit of physical therapy to overcome it. I have another family friend, however, who, he runs a restaurant, and he was a lot on his like knees, like, getting like moving things around and stuff. And so over time he developed sciatica. He had to get a surgical procedure to correct the sciatica. So there's different gradations of severity, right? Some people, they can just take a muscle relaxant. Maybe they can take like anti-inflammatories, or they can get a cortisone shot and it will help reduce the inflammation. Some people require surgical intervention. So. All right, let's talk about, what's up? You could do that. Yeah, if it's at the level of the vertebral column. Yeah, you could do that. Yeah, foraminotomy. So you like, if there's any sort of like, extra bone growth around where the nerve comes off at the level of the vertebral column, you could do that as a procedure if that's what the underlying cause is. So you can get, I forget the term for it, where you have extra bone growth. Yeah, there's stenosis. Is that what it is, though? There's, what, osteophytes? You could get that. Yeah, you could get misalignment of the vertebral column. That would cause it. Scoliosis, very severe scoliosis. Very severe scoliosis, bulging discs, right? So herniated discs. I'm trying to remember the term for where you have like stenosis of those openings within the vertebral column. I can't remember off the top of my head. But anyways, you guys are asking me questions that I embarrassingly cannot answer off the top of my head. So let me look at that as well. So stenosis. All right. So let's talk about osteoclasts and osteoblasts and how those guys work. So this is, again, another review from way back when you guys took 210. So with osteoclasts are the ones that crush bone, right? So they're the ones that break bone down. Osteoblasts are the ones that build bone up. For osteoclasts to get activated, you have to have the rank ligand binding to the rank receptor, right? So rank L is going to be the ligand, so it's going to act as a lock and key, and then when it binds to the rank receptor, that's where you have activation of your osteoclasts. What are the things that can prevent this from happening? So osteoprotegrin is one of the major things that comes into play to help prevent this from happening. So osteoprotegrin is going to block the rank ligand from binding to the rank receptor. With rank L, that's going to be secreted by osteoblasts, right? Because if the osteoblasts are building up bone, you don't want to have activation of the osteoclasts. So that can be secreted by osteoblasts. And then parathyroid hormone is also going to be seen to affect the rank L expression. So parathyroid hormone, what does PTH do? What's the whole purpose of parathyroid hormone? To increase calcium levels. Good, exactly. So in order to increase calcium levels, you activate your osteoclasts to help crush down the calcium, release calcium into the body. And then osteoprotegrin, we just talked about that. That's going to prevent the activation of osteoclasts. Let's watch a little video.
Osteoclasts and their precursor cells are regulated by different pathways and molecules. One key regulatory molecule is a protein, rank ligand, which is produced by a variety of cell types, including osteoblasts and their precursor cells. This protein has been shown to exert its effects on osteoclasts and their precursors through an interaction with the cell surface receptor, rank. The interaction between rank ligand and its receptor, rank, triggers the activation of signaling pathways, which are involved in the differentiation, activation, and survival of osteoclasts. Such signaling pathways can trigger the fusion of precursor cells to form mature multinucleated osteoclasts. On these mature cells, rank ligand can interact with its receptor, promoting osteoclast activity and survival, leading to increased resorption of bone. To balance the effect of rank ligand, osteoprotegrin, or OPG, is secreted from osteoblasts. This protein acts like a decoy in binding to rank ligand, preventing rank ligand from interacting with and activating its receptor on the surface of osteoblasts. Various hormones and cytokines modulate the balance between rank ligand and OPG. For example, parathyroid hormone stimulates the production of at the same time repressing the expression of OPG. That's thought to increase the activity of osteoclasts. Conversely, estrogen can increase the expression of OPG, its rank ligand signal. These changes, which are thought to reduce the activity of osteoclasts, may contribute to estrogen's ability to preserve or increase skeletal mass.
All right. And so I looked up just now the with spinal stenosis with sciatica. Yeah, so the framinotomy, that would be a potential therapeutic intervention if you had spinal stenosis. And then I also looked up, for your question, I just looked up the whole piriformis syndrome. I saw some pretty good images that kind of depict that pretty well. I'll start including that in my future lectures. There's a bunch of images that are available online. I totally spelled that wrong. So this is where you would get the impinging, right? So you have like the piriformis muscle causing impingement of the sciatic nerve. So there's one good image there. What was the other one that I was looking There's one right there. It shows the piriformis muscle and how it's basically kind of acting like a nutcracker. It's not a nutcracker syndrome, but it kind of looks like that. Yeah, it's going underneath. Yeah, that's what it is. It's a hypertrophy. That's why if you have like excess movement, right? If you're like bending down a lot, so all that stuff, if you build up that muscle too much, right, then that's going to start causing the actual impingement on the nerve. Cool. All right, so let's move on. All right. So how do sex hormones affect this? Right, so with when an individual is younger and they're producing adequate amounts of their sex hormones, especially for women with estrogen, that's going to help inhibit your osteoclasts, right? And so you're going to actually get more of your osteoprotegrin being produced. Osteoprotegrin reduces the activation of osteoclasts. You're going to have reduced rank L expression. So you're going to get more bone formation versus bone resorption. Once you're postmenopausal, you're going to have reduced levels of estrogen, right? And so with reduced levels of estrogen, you're going to get the opposite taking place. You're going to get more bone resorption than bone formation. And then this can also happen with guys with androgens. If you have reduced androgens, because over time, men's testosterone levels, start to plummet a little bit. And so over time, you can actually get reduced androgens, which can also do something similar, where you get excessive amounts of osteoclast formation, reduced osteoprotegrin being involved in that as well. So both estrogen and testosterone are going to be really important for maintaining your bone density and your bone mass. So what's going to happen if you don't have proper amounts of bone density and bone mass? There's a couple steps, right? So you're going to have osteopenia. If you remember, the term penia just means you have less of whatever thing that you're looking at. So like leukopenia, you have reduction in your leukocytes. Thrombocytopenia, you have reduction in thrombocytes. So osteopenia is where you have reduction of your bone mass. So osteopenia would be the step before you get into osteoporosis. Osteoporosis is kind of like the final step of reduced bone mass. And then there's different severities of osteoporosis. Peak bone mass, depending on what textbooks you read, can be somewhere in your 30s. Right? So peak bone mass, anywhere between 30 to 40 years old, is where your bone density is going to be at its height. As you get older, your bone density starts to dwindle. So with osteoporosis, that's where you have the reduction in your bone density. Don't really bog yourself down with the normal values for bone density. But for normal bone density, 833 milligrams per centimeter squared. When you're in osteopenia territory, you're going to be below 833. Once you're below 648, that's where you get into osteoporosis territory. So what's going on with osteoporosis, aside from just estrogen levels, right? Because if you're postmenopausal, reduction in estrogen is going to cause osteoporosis. Other things that can come into play too. People who live a sedentary lifestyle and they don't really do much, right? Maybe they're staying in bed for too long. Maybe they're living a very sedentary lifestyle and working in front of a computer at their cubicle. Those are going to be risks for osteoporosis. If you don't get enough vitamin D, that's going to be a risk for osteoporosis. We're also going to talk about osteomalacia later on. That's going to be directly associated with vitamin D deficiency. And then, of course, your reduction in your sex hormones, both estrogen as well as testosterone. Other things that you might see, if you have any sort of mutations that affect your osteoprotegrin, that affect rank L expression, that affect the rank receptor, glucocorticoids. If you're taking glucocorticoids for a prolonged period of time, that could affect your rank L and osteoprotegrin. And then also, if you have too much parathyroid hormone. So if you had like a parathyroid tumor that's overproducing parathyroid hormone, that could also cause osteoporosis, right? Because it's going to be overly activating your osteoclasts to break down your bone minerals. How do you test for it? You could do X-rays, and you could do a DEXA scan. So that's going to be your dual X-ray absorptiometry. That's a hard one to pronounce. Signs and symptoms, fractures obviously is going to be very common. You're going to see lots of fractures. Common site of fracture for an older individual, your femoral neck. If you see femoral neck fractures, that's going to be kind of more seen in older individuals with osteoporosis. But you can get fractures of other areas too, so like your vertebral bodies, right? You know, over time, people get shorter. It's kind of normal, right? So over time, you'll start seeing the person getting like compression fractures or the vertebral bodies, which makes them, you know, it shortens their stature a little bit. You got a question? Interleukin-6. I would have to look into that, but yeah, I mean, interleukins do a lot of things, and way beyond the scope of this class. But good, yeah, IL-6 is one of your inflammatory interleukins, right? That's one of the ones that causes, like, you know, elevated temperature, right? One of your pyrexics. But that's a good question. Look it up and send me an article that talks about that. That might be something that, if it's relevant, I might include it in my future lectures. Diminished height, right, is going to be one of the main things that you see over time. And then kyphosis. So there's two major postural changes when it comes to your vertebral column. One's going to be lordosis, and the other one's going to be kyphosis. Kyphosis is where you're kind of hunched over. Lordosis is where you have excessive arching of the back. Lordosis can actually be pretty normal for pregnant women. So when a woman's pregnant, lordosis is going to be a common thing seen in pregnant women. But otherwise, it's not common. Otherwise, you really shouldn't be seeing those types of changes in the vertebral column. So let's talk a little bit about the DEXA scans. So with the DEXA scan, there's two major things you're looking at. It's going to be the T-score as well as the Z-score. The T-score is going to be comparing bone density to younger adults, versus the Z-score is going to be comparing your bone density, bone mineral density, to people within your actual age group. And don't worry about these values. I'm not going to test you on these specific values on a DEXA scan. But if you want to nerd out a little bit on what those values actually mean, this is a good graph that will help guide you in the right direction. So your T-score, that's going to be comparing you to your younger individuals, right? So your T-score, if you have between 2.5 and -1, that's within normal limits. If you are between -1 to -2.5, now you're in osteopenia territory. And then if you're below -2.5, that's where you're now in osteoporosis territory. Okay? But like I said, I'm not going to test you on those values for this class. So osteopenia and osteoporosis. We talked already about hormone changes, so estrogen changes. Age can affect that, obviously, right? The older you get, the less bone density you're going to have. Malignancies, so different cancers, especially if you had like a parathyroid type cancer that's releasing way too much parathyroid hormone. Chronic renal failure. Yeah, so vitamin D, exactly. So if you have renal failure, you know, one of the big things that happens with, you know, your kidneys is you have activation of vitamin D, right? And so if you aren't getting enough vitamin D, then you're not going to be getting enough calcium, and then that's eventually going to result in reduction in mineral deposits within the bone. So anyways, if a patient is on dialysis or if you have a patient with any sort of renal issues, they really should be supplementing with vitamin D to be one of the things that they should take as well. So signs and symptoms, compression fractures, we already talked about that, reduction of your overall stature, and then testing, of course, DEXA scan would be the main way that you test for that. You can exercise to help treat this, right? So if you do any sort of weight-bearing exercises can help to prevent osteoporosis and osteopenia. Whenever you're stressing the bones out during exercise, that's going to help like recruit osteoblasts to the area to help build up the bone and further strengthen the bone. Of course, you can give the person calcium. I should put a 2+ on there. Calcium and vitamin D supplements, and then hormone supplements if they're if it's a person that's like postmenopausal. So here's another overview of what's going on with osteoblasts and osteoclasts, bone formation. So you have ossification, that's where you're forming the bones. That's going to be associated with osteoblasts, secreting the osteoid, creating a matrix. And then the osteoid contains collagen, right? Collagen is going to be really important for any sort of connective tissue. And then you have your calcification taking place. And when you have calcification, that's involving mineralization. And hydroxyapatite is going to be the major compound that's going to be contributing to your mineralization. So hydroxyapatite is going to be involving hydroxy, it's going to involve calcium, as well as phosphate groups. Those are all coming into play to allow for mineralization to take place. So if you have a bone mineralization disorder, these are different conditions that can affect the creation and formation of hydroxyapatite. And so rickets and osteomalacia are the two major ones that we're going to be talking about in this class. Rickets, that's going to be involving children. And if you have osteomalacia, that's involving adults. Okay? So for children that are vitamin D deficient, that's going to result in rickets. If an adult is vitamin D deficient for whatever reason, that's going to be osteomalacia. For osteomalacia, some of the major causes are going to be reduced sunlight exposure, right? Reduced vitamin D intake, and maybe even malabsorption. So if the person maybe had like a portion of their GI tract resected for whatever reason, maybe they had like Crohn's disease or something like that, or if they have like celiac and they have like any sort of malabsorption issues, like diarrhea, chronic diarrhea, all those can result in reduced vitamin D intake. What happens when you get osteomalacia or rickets? Your bones are actually going to be very flexible. So you're not getting calcification, but you do have collagen still. So you're still going to have like collagen scaffolding in the bone. The collagen's flexible. The mineralization is what provides the actual integrity, the structural integrity to the bone. So if you don't have mineralization, you're going to have soft, flexible bones. And that's why you see the bowing of the legs for kids that have rickets. Like I put over here, you're not responsible for phosphate in this, but this is what's going on with osteomalacia. If you have too little vitamin D, you're going to have too little calcium. What's going to happen with too little calcium in your body? You're going to have elevated levels of parathyroid hormone because your parathyroid gland is going to try to increase the levels of calcium within your body. What happens if parathyroid gets released in excess? You're going to have excess osteoclast activation, right? And too much osteoclast activation is going to reduce your bone density. So it's a long sequence of events that eventually winds up in extra PTH, bone demineralization, and then you're going to have extra serum phosphate levels within your bone. If you have too much serum phosphate level in the bone, from the bone being released, you're going to get calcium phosphate deposits in different areas of your body that you don't want. So that results in metastatic calcifications, and that's what's going on with these images here. These radiographic images are showing extra calcium and phosphate being deposited in different parts of the body where they should not belong. What was your question? The levels. You probably won't because your parathyroid gland is trying to come in to compensate for it, right? Yeah, so that's the reason why. That's why the reason in this whole cascade, it starts with vitamin D deficiency. When you have vitamin D deficiency, the next thing that you're going to see is reduced calcium. So you're going to get hypocalcemia, at least in the short term, but then parathyroid hormone is going to try to correct for that hypocalcemia. And that's why you have parathyroid release. So then eventually it's going to bring up the level of the calcium, but at the expense of the bone. Right, so the bones are going to start getting demineralized as a consequence. So yeah, that's a really good question. That's exactly what's happening with this cascade. So if you had renal failure, for example, low vitamin D, hypocalcemia, to correct the hypocalcemia, parathyroid comes in to help increase the levels of calcium. So you get normal calcium levels as a consequence, but at the expense, like I said, of bone. So you're going to get osteomalacia. Now, if you have too much parathyroid hormone over time, then that's when you start getting hypercalcemia. So this person would eventually develop hypercalcemia, right? Because the parathyroid is really trying to like increase the level of calcium reserves. And then that's when you start getting this whole situation with calcium being deposited where it doesn't belong. So what are the signs and symptoms of osteomalacia? You're going to see pain. You're going to see bone fractures, vertebral fractures, bone malformation, and then a waddling gait. Treatment, you want to help to restore calcium levels. You want to give them vitamin D supplements. If the person has renal issues, obviously the main thing that you do with those patients is dialysis. And if they're lucky enough to get a transplant, that is, of course, going to be the main way that you fix that. So this is rickets in young kids. One of the things that you see on their thorax is you're going to see these this like rosary type formation. That's where you have costochondral, like the bones are not being well formed, and then you can tell between the cartilages and the bones that there's going to be some differences there. It kind of looks like a little bit of a rosary. And then with the legs, you're going to get the boning of the legs because the bones are now going to be more flexible. They're going to be softer. All right, what's up? No. What was he? He was whipping? Yeah. And while whipping something, he broke his... No, I don't know the dance. Ooh. I have no clue. I have no idea, but it could be. How old was the kid? Oh, no. I mean, when you're that young, you know, your bones are there's still like quite a bit of cartilage in your bones, right? Because they're still developing. I mean, the epiphyseal plates don't close until you reach puberty. So that could be part of it. Maybe he just like, that's terrible. That's really terrible. Could be. It could be anything. I mean, I can't speak for that kid because, you know, obviously you have to do a lot of workup to be able to find out what happened. But that's a scary situation. Any questions about rickets versus osteomalacia? All right, good. So we're chugging along here. So now let's talk about rheumatoid arthritis versus osteoarthritis. So when we talk about rheumatism, that's going to be involving pain and stiffness of the musculoskeletal system. Versus arthritis is specifically the joints, right? So if you have rheumatoid arthritis, it's going to be a combination of musculoskeletal issues plus the joint involvement as well. So let's first talk about osteoarthritis because it's the simpler of the two. With osteoarthritis, it is basically just wear and tear, right? Basic wear and tear over time, whether or not you're an athlete versus just, you know, a normal person, over time you're going to see damage of those joints, right? The hyaline cartilage over time is going to just undergo normal wear and tear. So in other words, age is going to be one of the major factors of this, right? There can also be genetic issues that come into play, but age is really going to be the main thing. So what you're going to see is loss of those articular type cartilage over time with the irritation and inflammation of the bones. Once you start getting bone to bone contact, you're going to start seeing osteophytes and bone spurs coming in. So this is an osteophyte / bone spur. This is normal. You're not seeing any osteophytes or bone spurs. If you see a bone spur, that indicates that there's inflammation going on in the joint due to bone and bone contact. It increases with age, right? It's especially more common in women versus men. And the major areas that are going to be affected, hips, you see it in hands and knees and your spinal column. My piano teacher, when I was a kid, she started developing osteoarthritis in her hands. It was really sad. She stopped playing piano over time because it was so bad, like she wasn't able to play anymore. So you can get it in your hands. When I was doing my orthopedics rotations, hip replacements, knee replacements, that's like bread and butter orthopedic surgery, right? Some orthopedic surgeons will like specialize only in hip replacements or only in knee replacements, and that's what they do day in and day out. And they make a lot of money doing that because even though they're doing the same damn thing over and over and over again, those procedures are pretty pretty intense, very invasive. If you ever want to see some brutal surgeries, go into orthopedics. It's like caveman medicine. They'll go in there with like literally chisels, drills, hammers, and they just whack things. And like the people that go into orthopedics are generally jocks, or they're like very like aggressive type people. And 90% of the orthopedic surgeons I've worked with were absolute assholes. Did I tell you anything about my orthopedics? Okay, so let me give you a good example of the kind of guy that goes into orthopedic surgery. There's this one guy, amazing dude. His name is Dr. Walsh, and he was from Wales. He was a Welsh dude. And nice guy outside of the OR, but the moment he goes into the OR, it's like Dr. Jekyll and Mr. Hyde. He just completely changes. And he was in an anger management program because he had so many complaints levied against him. One example, one of the nurses told me about this. She was like, yeah, someone passed him the wrong scalpel blade. And he's like, that's not the fucking scalpel blade I wanted. And he threw it across the room with like everybody there, patient on the table, other like nurses and stuff. Like the guy was unhinged. It's totally crazy. But he was an amazing surgeon. And so, of course, they didn't fire him. They just put him in an anger management program. I don't think the anger management program worked too well. He yelled at me a few times. Like I was helping to like set the patient up on the table, and I was gonna scrub in, and you know you wear like when you scrub in you wear these boots and stuff, and he was like, "Are you gonna scrub in today?" I'm like, "Yeah, I am." He's like, "Then why aren't you wearing your fucking boots?" And he's from Wales, so he had that crazy weird accent. And I was like, I was gonna put the boots on, but I was like prepping the patient. So the dude was crazy, but pretty amazing. Actually, I looked him up the other day because I was curious to see if he's still in practice. He's actually still in practice, and he's an amazing dude. Working at the same hospital under NYU. So wild dude. He almost like slammed my finger because when I was scrubbing into surgeries, like I would help with the retractors and all that, and also help like holding like the chisels and stuff. I once had my thumb over the chisel, and he was like about to whack it, and I was like, "Whoa!" Like that would have been really bad. You know, especially you're scrubbing in. Like if you broke through my gloves and like it started bleeding out like into the patient, like inside the patient, like that would be a really bad situation. But like I said, it's caveman medicine. Super interesting stuff. These are the different gradations of osteoarthritis. I'm not going to test you on this, but really severe is going to be grade 4. Pretty bad is going to be grade 3. Okay, so the reason why I included that in here is because this was a grade 3 advanced osteoarthritis. So I wanted to put this chart in here so you guys see it. I didn't put it into your lecture notes, but this is just something that gives you like an idea of what's going on. So if you were to do an X-ray, you would see a nice space in between the bones, right? So that would be normal. Once you start seeing bone-to-bone contact, that's really bad, right? So that means that the meniscus and like other cartilages that are involved in the area are completely getting degraded and destroyed. What are the things that you see with osteoarthritis? You're going to see stiffening that is worse in the morning. And joint stiffness is going to it's going to be worse in the morning. And then it can subside after usage, right? So you can eventually see progressive improvement with the stiffening. But the joint pain is going to be worse in the evening. So the more stuff that you do throughout the day, it's going to worsen the actual pain. So you have stiffness that's worse in the morning, but then you have pain that's going to be worse towards the end of the day. Right? That's through repeated movement and inflammation of the affected joints. You might see effusions as well on the hands. So you could see Heberden's nodes. That's going to be in the distal interpharyngeal joint. And then the Bouchard's nodes is going to be in the proximal interpharyngeal joint. So Heberden's nodes, it would be like, at the very tip of your fingers versus the Bouchard's nodes closer, right? Closer to your the proximal side of your hand. And then here's a couple images of what that would look like, right? So if you have osteoarthritis of your acetabulum, right, you're going to have destruction of the joint over time. Pretty bad. That's what the knee would look like if you had osteoarthritis. Just total degradation of the hyaline cartilage being involved. So how do you treat it? You can help to, you can increase rest, right? Tell the patient just to rest more. which of course not always the best option for some patients. You can have them use things like canes, crutches. If they're obese, weight loss, you can give them analgesics, but ultimately, over time, surgery is going to be like the only option. And there's going to be partial replacements, and there's going to be total replacements. So with the partial replacement, you're only replacing part of the joint. Like a total replacement, you're replacing the entire thing. So with like a total hip replacement, you're going to be replacing the acetabulum itself as well as the femoral head. So you're going to be replacing both. If it's a partial replacement, you're keeping the acetabulum, but you're going to be replacing the femoral head. And then generally speaking, with an older patient, you're going to want to do the surgery bilaterally. So they'll do one side first, and then over time, they're going to have to get the other side done as well. Sometimes they can do it like within a year. Sometimes some patients hold off a little bit longer than that, but usually has to be bilaterally done. So. That can help. It can help increase the size of the cartilage because you have, when you're exercising, you're kind of like bringing more temperature, right? It's getting like increasing the heat, so that helps to like expand the tissues a little bit. And then also you're getting like a little bit more blood flow, so you're getting more fluids to the area. But that's like short term. It's not going to be a long term change. Don't know if it's a long term thing that you would see increasing the meniscus. Look it up and contradict me. Look it up and prove me wrong, and then send me the article because I'd be curious to learn more about that. But no, as far as I'm concerned, that's only in the short term when you're exercising where you're going to see changes of those tissues, or like the meniscus. All right, so that's osteoarthritis in a nutshell. So now let's move on to rheumatoid arthritis. Rheumatoid arthritis, this has nothing to do with wear and tear, right? This is an autoimmune disease. So in other words, you have overstimulation of your immune system, and then all of a sudden you're getting immunoglobulins attacking the affected joints, right? So this has nothing to do with wear and tear. It's autoimmune. And unfortunately, for ladies, it's going to be way more common in women than it is in men. Age of onset is usually in the 40s, all the way into the 60s. And you're going to get symmetric changes of the joints. So you get symmetric deformities as well as swelling and tenderness, and it's going to be destroying the synovial membrane. The major areas that are affected are going to be your fingers, hands, elbows. You can also get in other areas too, like your feet, lower extremities, areas like that. But it is extremely deforming, extremely debilitating, especially in advanced stages of RA. So this is the whole process of what's going on with rheumatoid arthritis. So let's kind of go through it. So you're going to have your CD4 helper cells. Those are going to activate your B-cell lymphocytes as well. The T cells, they can affect the macrophages and fibroblasts within the joints. You're going to get that rank L ligand affecting the osteoclast, so you're going to get destruction of the bone itself. Inflammatory cytokines can affect other cells like fibroblasts, chondrocytes, etc. So you can get the cartilages being affected as well. Then when the B cells are affected, that's where you get the formation of your rheumatoid factor. RF, or rheumatoid factor, is something that you can actually test on lab work. So if a person has rheumatoid arthritis, this is one of the things you want to look for. It's going to be rheumatoid factor. And then that's going to be causing the formation of those antibodies. And that's where you have the autoimmune component, right? So you have antibodies that are going to be affecting your joint tissues. So it's inflammatory. So what are the things that you might see? You might see fever. You might see fatigue and inflammation. You might also see general wasting, anorexia, weight loss, stiffness of the joints. Now, unlike osteoarthritis, where you see the pain getting worse at the end of the day, the pain and stiffness is worse in the morning, right? So it's going to be worse in the morning, especially 1 hour after getting up, and then over time throughout the day, it gets a little bit better with repeated use, right? That's going to be completely opposite from osteoarthritis. You do have stiffness in the day with osteoarthritis, but you're going to get more pain towards the end of the day after repeated use. What are some of the joint deformities you might see? You might see swan necking. You might see this little boutonniere's deformity. Boutonniere, it's like you're maybe hitting a button too much with your thumb, so it kind of looks a little excessively arched. You can see a little bit of the ulnar drift, where you have I don't know what kind of rotation you would call that, but you have, you know, a little hyper, what would you call that type of flexion? Where the ulnar drift, where you have too much flexion of your wrists. So that's the ulnar drift. And then the boutonniere's deformities. So here's a radiograph of what that looks like. With rheumatoid arthritis, it could be genetic as well, right? So you have a genetic component. It could be environmental components as well. But the big thing about rheumatoid arthritis is that it's going to be autoimmune in nature. So because it's autoimmune, you're going to look for the rheumatoid factor, or RF. The other thing you can look for too is your anti-citrullinate proteins, or ACPA. These inflammatory markers, CRP and ESR, are kind of crappy tests. They only tell you that there's something going on that's inflammatory in nature, right? So C-reactive protein, erythrocyte sedimentation rate, they're generic tests. They basically tell you that something's going on. You need to further investigate. So with an RA patient, you'll check for their RF rheumatoid factor. Treatment. You can give them NSAIDs, but you can also give them DMARDs. So that's disease-modifying anti-rheumatic drugs. Methotrexate is going to be one of the most commonly prescribed drugs for rheumatoid arthritis. We can also give them azithromycin and cyclosporin. And then there's another class of drugs that can be used for RA. So those are your B DMARDs. Those are biological. You can also give them monoclonal antibodies as well. Those can help to reduce the autoimmune component of the disease. Let's watch a little video.
Bones provide support for the body and aid in its movement. The place where two or more bones meet is called a joint. Joints may be immovable, slightly movable, or freely movable. A synovial membrane surrounds movable joints. Inside the membrane, synovial fluid lubricates and nourishes joint tissue, such as cartilage. Articular cartilage is a tough, slippery covering on the ends of the bones, which allows smooth joint movement. Joints give the body flexibility, precision of movement, and help in supporting the body's weight. Arthritis is any disorder that affects joints. It can cause pain and inflammation. Rheumatoid arthritis is the second most common type of arthritis. The joints most commonly affected are in the wrists, hands, knees, ankles, and feet. It typically occurs at the same joint on both sides of the body. It can also affect other organs in the body, such as the eyes, skin, heart, lungs, kidneys, nervous system, and digestive tract. Rheumatoid arthritis is an autoimmune disorder. This means the body attacks itself by mistake. In rheumatoid arthritis, the immune system attacks joint and organ tissues. Here's how it happens. The white blood cells of the immune system move into the joint. They release chemicals called cytokines, which attack the cells of the synovial membrane. These chemicals cause synovial cells to release other destructive substances, They also cause the synovial membrane to grow new blood vessels and form a thickened area called a pannus. Over time, as the pannus grows, it invades and destroys areas of cartilage and bone inside the joint. Inflammation causes fluid buildup in the joint, making the joint swell. Eventually, without treatment, the joint space narrows and ankylosis can occur. Ankylosis is fusion, or growing together of bones in the joint. This results in the loss of the ability to move the joint. There is no cure for rheumatoid arthritis. However, doctors commonly prescribe various combinations of the following medications that, when taken together, can reduce inflammation and pain and slow down joint damage. These include non-steroidal anti-inflammatory drugs, or NSAIDs, steroids, and standard disease-modifying anti-rheumatic drugs, or DMARDs. If standard DMARDs aren't working, doctors may prescribe newer drugs called biologics, also known as biologic DMARDs. Physical and occupational therapy, along with low-impact exercise, can increase muscle strength and help keep joints limber. For severe rheumatoid arthritis that has not been helped by other treatments, a doctor may recommend a surgical procedure. For example, a joint replacement procedure, also known as an arthroplasty, may be recommended. For joints that are difficult to replace, joint fusion, also known as arthrodesis, may be recommended. During this procedure, the joint is removed and the bones are fused together with bone graft. Another surgical procedure for severe rheumatoid arthritis is a synovectomy. During this procedure, the synovial membrane surrounding the joint is removed. In some cases, an arthritic joint may need to be replaced with an artificial joint. For more information, talk to a healthcare provider.
All right. All right, so any questions on RA versus OA? Cool. All right, so let's move on to osteomyelitis. So osteomyelitis is an infection. So this is bacterial in nature. Who are some of the individuals that are going to be at greatest risk for developing osteomyelitis? It's going to be diabetic patients. So why is that? Why do diabetics often get osteomyelitis? So I had a colleague, he's a podiatry guy, and he jokingly said that part of his job is to make people shorter. A lot of the patients that he works with are diabetic patients. And what happens with diabetes, you can also get this with hypertension too, but diabetes especially because you get lots of stuff going on, right? Because if you have too much sugar floating around in your circulatory system, as my colleague Dr. Jackson likes to call it, he says it's like little shards of glass. I think about sugar as being little shards of glass, and they cause damage to like everything in your body. So it can damage your vasculature, it can damage your nerves, it can damage so much. So like you get renal failure, things like that, peripheral neuropathy. You can get retinopathy. Well, you know, one of the big things that causes blindness in diabetics is retinopathy. And so when you get peripheral neuropathy, sometimes you get numbness and tingling and loss in sensation in your feet, your hands. If you get that in your feet, what happens? You get like a cut, right? You get a cut and you don't notice it. And then all of a sudden you start developing an infection. And then once that infection gets to a point where it enters into the bone, that's when you get osteomyelitis. And with osteomyelitis, there's lots of different organisms that can cause it. So Staph aureus is going to be one of the major culprits. You can also get it with group E strep. You can get it with Haemophilus influenza. You can get it from bites. So if you get bitten by a dog, you might get Pasteurella. Right? So a lot of these different types of bacteria can cause it. Gram negatives. One of the most foul-smelling things I ever smelled on a patient was Proteus mirabilis on the person's foot. It was a diabetic. He had a diabetic foot ulcer, and it was so awful. Like, we had to take like cultures, and that's when it came back positive for Proteus mirabilis, which is one of the organisms that causes UTIs. But you find it in your GI tract. It's a common gram-negative. So lots of different organisms can affect the bone. So diabetics are going to be the most commonly affected. You can also see that with alcoholics. You can see that with immunocompromised patients. For treatment, you can treat it with antibiotics, but this is the major thing here: surgical debridement and surgery to actually remove the affected bone. So during the next lecture series, we're going to talk about endocrinology. So there's a really graphic video I'm going to show you of what a diabetic foot ulcer surgery would look like, especially with advanced stage necrosis. This video is ridiculously awesome. So very brutal, but that's the kind of stuff that you deal with when you're working with patients with diabetes. Diabetes is really a scary condition because, people take it for granted. Folks, diabetes type 2 is really common because of the Western diet, right? So we have lots of hypertension and diabetes in the United States. And it's hard to tell people to put down the cheeseburger, right? So it's like one of those things where it's like sugary drinks, especially bad diet, all those things are really tough to intervene with. And so it's really hard to treat patients with diabetes. It's so bad that when I was working on infectious disease, my supervisor in infectious disease said, nowadays it's worse to get diagnosed with diabetes than it is to get diagnosed with HIV. Because HIV is actually really easy to treat. A lot of the patients, when I was doing infectious disease work, and we had like AIDS clinic every week, I had patients that came in that I would always ask them, when were you diagnosed? Sometimes it would be like 1991, 1992. And their lab values were insane, like really good. Like their CD4 count was normal, 0 HIV, like undetectable load, or their viral titers. So pretty amazing. You can really easily control HIV. You just take a combination of 3 drugs, the heart medications, but heart is the highly active antiretroviral therapy. So those are good drugs that they have some side effects, but diabetes is notoriously difficult to treat. Even if a person is taking metformin and other types of diabetic drugs, it can still be really tough to control their glycemic index, their glucose levels. So with osteomyelitis, when you want to diagnose it, you can do a CBC, right? To see especially if it got into the bloodstream, you would see leukocytosis as well, increased leukocytes. Cultures, you can do a blood culture or a wound culture of the affected area. You could do x-rays. So the patient that I was telling you about that had that foot ulcer, we took him off to x-ray to make sure he didn't have osteomyelitis. Thank God for him, it didn't make it to the bone. So no issue with that. You just have to, maybe surgically debride a little bit of the affected tissues. But if you get the infection entering the bone, antibiotic, surgical debridement, and surgery to remove the necrotic bone in the affected area. So pretty nasty situation. Osteomyelitis is terrible. And you can actually see that in orthopedic surgery too. Sometimes during the surgical procedure, the patient gets an infected bone from like a total knee replacement. They'll actually have to get part of the bones removed a little bit. Like they have to surgically debride the affected tissues and replace the joint. Right? That actually happens. It's rare, but it does happen. That's a scary situation. All right, gout. Gout, the disease of royalty. But now it's not. Now it's a disease of basically anybody can get gout. Gout is going to be mostly affecting the base of the big toe, as depicted in this image over here. And you can see a gouty tophus on an x-ray, right? Because you're going to have lots of uric acid crystals accumulating in those affected areas. And gouty tophi can not just be like a really uncomfortable situation in the foot, it can actually destroy part of the bone too. It can actually destroy part of the joint. So the underlying mechanism of gout is going to be uric acid accumulation. And uric acid is going to be something that you see as a byproduct of purine nucleotides. So With hyperuricemia, that's where you get inflammation, and you can get that uric acid accumulating in different areas in the body. So it can affect the joints. It can also affect areas like the kidneys as well. What causes it? Well, we talked about high purine-rich diet. So if you're eating too much red meats or like seafood, if you're drinking lots of alcohol, those are all things that are going to be increased risk factors for developing gout. I had a patient who had gout, and when I was doing my workup on him and stuff, I was like, so, got to the part about drinking alcohol. I'm like, so how much do you drink alcohol? He's like, oh yeah. And I'm like, how much do you drink on average? And it was like a ridiculous amount. Like even I was surprised. I'm like, damn, you drink a lot. And I'm like, you know that alcohol is one of the major contributors to gout? He's like, oh, I had no idea. I'm like, well, now you know. So maybe cut down on the booze a little bit. You can do that. You can do lifestyle modification. So you can reduce alcohol consumption. You can try to cut back on red meats and things like that. But there's drugs you can use as well, which I'll talk about in a second. But signs and symptoms, painful joints, right? Usually it's going to be one joint at a time. And then tophi, those are going to be these white nodules right here. So just imagine how painful that is. That just looks so excruciating. So that's a gouty tophus. Tophi, tophus would be singular, tophi plural. And then you can also get kidney involvement too. So you can actually have that uric acid accumulating in the kidneys, causing nephrolithiasis with uric acid stones. So pretty bad. So dietary purines, those get broken down, and they could accumulate in different tissues in your body, causing gout. So what are you going to see on those joints? You're going to see really inflamed, tender joints. It's extremely painful. It's excruciating. Those people have a really hard time walking if it's affecting their toes. You would want to take a rheumatoid factor just to see if it's, it could be rheumatoid arthritis. So you want to rule that out. But you can do an arthrocentesis or a joint aspiration. You take a pretty large gauge needle, go in there, pull out a little bit of the synovial fluid, send it off to lab, and if it comes back positive for uric acid crystals, then you can diagnose the person with gout. There's a condition called pseudogout, which is not uric acid, but it's calcium pyrophosphate. So I'm not going to test you on that one, but it looks like gout, but it's not. So that's why it's called pseudogout. How do you treat it? Dietary change, lifestyle modification. Tell them to cut back on the booze. Don't eat as much, red meats, organ meats, shellfish. Allopurinol is one of the gold standard drugs to be used against gout. You can use colchicine as well. NSAIDs, that's really not going to do much. NSAIDs are going to just help with the inflammation and the pain. Right? But allopurinol is one of the drugs that actually helps to reduce the uric acid levels within the blood. So that's one of the best drugs for you to take if you have gout. What happens if you have severe arthritis? You eventually develop arthritis mutilans, which is where it's literally mutilating those joints. It's really bad. So it's generally kind of like advanced stages of rheumatoid arthritis is kind of one of the major causes of that. Really bad. You can also see that with psoriatic arthritis, which we're not going to talk about in this class, but rheumatoid arthritis in advanced stages can result in arthritis mutilans. So absolutely devastating condition that causes severe deformities of those affected joints. Myositis ossificans. That's where you're having calcium deposits in areas that they don't belong, but it's going to be due to muscle injury. So if you maybe get into a little bit of a blunt trauma, or if you're a horseback rider, so this actually happens in equestrians where they're riding on horseback a lot, which, if you ever rode on horseback, it really, the next day you feel it. So it causes a lot of pain in the derriere. So you can get rider's bone in equestrians, drill bone in infantry soldiers, so if they're training a lot on their rifles, and thigh muscles in athletes. And so you're basically getting calcifications where they do not belong. So I included some x-rays and radiographs here for you to see what that looks like. So you're having calcifications in areas where it doesn't belong. So that's myositis ossificans. All right, let's now talk about osteosarcoma. And this is the only cancer that we're going to talk about when it comes to bones. But it is one of the most devastating types of bone tumors. It's really tragic because it involves amputation. So back in the day, now there's better treatments, but back in the day, usually the person would have to get a total amputation above the knee, right? Because generally it's going to be affecting the distal femur. So you have to do an above the knee amputation for those patients. But now there's a procedure that I'll show you I'll show you a video that talks about where you can do a modification of the affected area, and so they can actually have a pretty solid prosthesis where it mimics an actual knee, but it's still an above the knee amputation. But I'll show you a little video on that. So, what's going on with osteosarcoma? It is a very, very aggressive tumor, and the sad thing about it is that it affects younger individuals. It's usually going to be a person in their teenage years. Okay, so it's a person in their teenage years. It can also affect older people too, but generally speaking, you're going to see younger individuals being affected. You see it more in guys, and it is one of the more common of the bone tumors. And it's going to happen in long bones, especially in the distal femur and the proximal tibia. So that's why you need to get a total above the knee amputation for that. But there's rotationplasty, which is a limb salvaging type of procedure where you're creating an artificial knee, and then you're rotating the foot so that you can actually put that into a prosthetic so it mimics an actual knee. So the prosthetic is actually pretty interesting. I'll show you a video on that in a second. But what's going on with the signs and symptoms? You generally get mild discomfort and pain in the affected area, and over time it gets worse and worse and worse. Oftentimes in a clinical vignette, you'll hear, oh, it's an athlete, maybe like a soccer player or like a basketball player or something. And then maybe while they're playing a sport, they got bumped in the leg. And then over time, they think it's probably because they got that knee injury. That's actually a distractor. It's not the actual injury. It's the fact that they already have a cancer that's growing. And then they got bumped in the leg. Maybe they got a little pain from that, and they're thinking, oh, wow, that was a really bad hit. I got really badly hit. But no, there's underlying cancer that's going on. Right? So that's a distractor, so don't be confused with that. But then the pain progresses until it's really bad, until they get an x-ray. And when they do the x-ray, this is what you see on the x-ray. Right? So you see all this like bony formation. So it's pretty nasty. So this is the rotational plasty video. Let's go ahead and watch the whole thing. Really cool.
My name is Gabby, and my dog there, and so they took out my knee area, which is the portion that's included, and they took my lower leg and foot, twisted it 180 degrees backwards, and reattached it to my upper thigh. So now my ankle acts as my knee joint, and whenever I point my foot, it straightens the prosthesis, and whenever I flex my foot, it raises the prosthesis. So step one, I put on my socks to prevent any rub spots or sores when I'm walking around or dancing. And then I just slide my foot into the prosthesis. Wrap it up. And now whenever I point my foot, it straightens the prosthetic, and whenever I flex my foot, this surgery allows me to dance, ice skate, rollerblade, rock climb, and puts no limit. It allows me to do anything I want to do. And it's definitely a unique surgery, and not for everybody, but it was worth it. live your dreams, and don't ever give up.
All right. So, pretty dramatic, huh? Very dramatic. This is what's going on with rotationplasty. So that's a breakdown. So they preserve all the major vessels. They preserve all the major nerves. Then they remove the infected area. Well, not infected, but the cancerous area. And then they do the whole reattachment and then rotation. They reattach all the muscles. Really amazing procedure. So it provides those patients with a lot of mobility. The other procedures before that, they would do like they would do a complete above the knee amputation. And there's been stories of like athletes, like runners, that will get this done. And the type of prosthetics that they would use have like a spring type mechanism, and they can actually run faster than normal people, which is really amazing because of like the spring mechanism. So it's really, really impressive stuff. I mean, the person can live a relatively normal life after they get the procedure done. So it is time for us to not do the quizzes questions and dismiss. We'll start off Friday with these quizzes questions, and then we'll get into the endocrine system. Any questions? All right, y'all. Have a great day. Take care.